Okay, we're going to move on to our next topic, and this is going to be an update on structural heart. If you're a cardiologist nowadays, structural heart is really sort of the new and shiny toy, and the thing that everybody is very, very excited about, rightly so. And one thing that we've learned about it, it's definitely a team sport. It involves disciplines within medicine and definitely disciplines within the fields of cardiology. The topic today is going to be presented by NCMA cardiologist Dr. Vishal Patel. Dr. Patel is got his undergraduate degree at Illinois and then went on to Baylor to medical school. And he's really a computer nerd who has great hands and excellent judgment. And therefore, he became an interventional cardiologist. So he's going to lead off the presentation, and then it's going to conclude with a panel discussion with Dr. Ashwani Bedi, our cardiac electrophysiologist, and Dr. Patrick Coleman, who you all know, who is the director of the Cardiac Catheterization Laboratory and Structural Heart at Santa Rosa Memorial Hospital. So I present to you Dr. Vishal Patel.
Okay, you guys can hear me? Okay, well, thanks for having me and giving me the opportunity to talk to you guys. It's actually really an incredible time to be an interventional cardiologist, particularly in Sonoma County, because within the last year, we've really expanded the breadth of services we can offer patients in terms of interventional cardiology with the development of the Tavor program. And we anticipate in the next few years to be able to grow that even further to offer other therapies that I'm going to talk to today. So while I'm not a hammer, sometimes I do feel that way when I'm, when we do a lot of cases, and this really structural heart has given us a lot of new nails to be able to treat patients with problems. So I have no relevant disclosures, and I'm going to talk to you about 4 topics today. And I've chosen these 4 because I think there's been a lot of data about them in the last few years, and there's a lot of important updates that I think it's important for particularly primary care physicians to be aware of. So we're going to start with Tavor, or transcatheteric valve replacement. So what is Tavor? Tavor is a procedure whereby a catheter is inserted via an artery, 95% of cases via the femoral artery. It's inserted across a patient's native stenotic aortic valve usually, and a stent is then deployed within that native valve. There's a sewn-in valve in there that's normal and functional, and it begins beating immediately, essentially, once the stent is deployed. The catheter is then removed, and the hole you made is then closed in any number of ways, typically percutaneously when it's done femorally, but we've also done cases from a transcarotid and subclavian approach for patients with poor iliofemoral access. And we've really come a long way since Tavor was first performed in man in 2002 by Dr. Cribier, to just a few days ago with Tavor being performed in McJagger in New York. So it's really, and in the last decade, there's really been a lot of data showing the efficacy of Tavor in a variety of patient populations. The therapy was initially tested with Tavor in the highest risk or inoperable patients, and we've subsequently extended the therapy to lower and lower risk patients. So the initial publication of the Partner 1 Cohort B trial tested patients with inoperable aortic stenosis. And the reason I show you this slide is not to show you how efficacious Tavor is, which it is incredibly efficacious, but to just show you how deadly untreated aortic stenosis is. So in patients with severe symptomatic aortic stenosis who are inoperable, half of them will be dead at 1 year. That's worse than a lot of metastatic cancers that affect people commonly. And 68% will be dead at 2 years. Tavor is incredibly effective for these people, resulting in a 25% absolute risk reduction, meaning you need to treat 4 patients to save 1 life at 2 years. So with that, Tavor was approved for inoperable patients, and then, like I said, we began testing it in lower and lower risk patients. So the Partner 1 Cohort A trial published in 2011, as well as the U.S. Pivotal Extreme and High Risk Surgical Cohort published in 2014. And these tested patients who were at high risk for surgical aortic valve replacement. And while there's no formal STS cutoff, an STS score is basically your 30-day risk of death from whatever cardiac surgery procedure you're considering. The general cutoff was an STS of 10. So basically, a heart team thought that patients had about a 10% risk of dying from surgical aortic valve replacement, which is 10% or higher, which is incredibly high. And you can see that Tavor in both trials, on the left in the PARTNER 1 trial, Tavor compared to surgery, equivalent outcomes in terms of death from any cause at 2 years. And with the core valve device, Tavor actually resulted in a lower mortality at 1 year compared to surgery, 14.2 versus 19.1%. So incredibly effective, as good or better than surgery. And with that, Tavor was approved for patients at high risk for surgical aortic valve replacement. And then in the last couple of years, we've had publication of the PARTNER 2 Cohort A trial and the SURTAVI trial, which tested Tavor in intermediate risk patients. So these are patients, your 70, 80-year-olds, your 70-year-olds with lots of comorbidities, or your 80-year-olds with minimal comorbidities who have an STS of 3, meaning a 3% risk of dying from surgery within 30 days. So, generally we'd consider them, on the lower risk side. And you can see that Tavor, shown in blue compared to surgery in red, no difference in death or disabling stroke at 2 years in the PARTNER 2A trial, and similar outcomes also in the SURTAVI trial. So Tavor seems to be just as good as surgery in terms of death or disabling stroke in intermediate risk patients. And so with that data, the FDA then approved the Edwards SAPIEN valve as well as the Evolut RN Pro valves for patients with intermediate surgical risk for surgical aortic valve replacement. And then most recently, and probably most exciting, is low risk data. So published in the New England Journal literally last month was the low risk trial. So this is the PARTNER 3 trial and the Evolut low risk trial on the right. And you can see surgical aortic valve replacement in blue and transcatheter aortic valve replacement in red. The most important things we look at in these trials really are death and stroke. And you can see that Tavor wins in both those categories at 30 days. Lower risks of both death and stroke at 30 days with Tavor compared to surgery in both PARTNER 3 and the Evolut low risk trial. These are not statistically different, but numerically lower with Tavor. This result carries out to 1 year. So at 1 year, you still have a very low rate of death with Tavor compared to surgery, much lower risk of stroke, same and identical in both trials. Where Tavor really struggles a little bit, and it's getting better, is pacemakers. So in the low-risk trial, if you look from the PARTNER 3 study, there's numerically higher risk of pacemaker in patients who had a Tavor compared to surgery. In the PARTNER 3 trial, not statistically different, but in the Evolut trial, there was a statistical difference with higher risk of needing pacemaker with Tavor compared to surgery. What about durability? Well, I think when the therapy first came out, a lot of people thought, oh, Tavor's good, but it's only going to last a few years. And I'll say that to many people's surprise, really, Tavor seems to be a very durable therapy. So this is data from the low-risk trial at 1 year of patients who need aortic valve reintervention. Surgery in blue, Tavor in red again, and you can see very few patients need aortic valve reintervention at 1 year, less than 0.7% in both trials with no statistical difference. What about longer-term data? Well, we have durability data from the original core valve trial, Tavor valve shown in yellow, surgical valve shown in blue. This is looking at their gradients across the valve. So when patients have severe aortic stenosis, they have a high gradient, and then it drops when you put your new valve in. And you can see that at every time point checked, Tavor valves have a lower gradient than surgical valves, and similar, they have a larger effective orifice area than surgical valves at every time point checked over 5 years with no signal for deterioration. So they seem to be quite durable. Sort of reinforcing that data, this is the NOTION trial, which looked at, it was sort of an all-comers trial with the original, a lot of patients getting the original sort of core valve, 80% low-risk patients, so kind of what you just saw in the low-risk trial. And Tavor valves are in orange here, surgical valves in green. At every time point checked over 5 years, Tavor valves perform better than surgical valves in terms of both mean gradients as well as effective orifice areas. So what are the take-home points here? So Tavor is indicated for patients at intermediate risk or higher for surgical aortic valve replacement. The low-risk data was just published, and we're hopeful that the FDA will approve Tavor for low-risk patients, but we'll have to see what they decide. It's associated with a lower risk of stroke than surgical aortic valve replacement, and that's been shown consistently in multiple trials. And the hemodynamic data suggests that Tavor valves are as or more durable than surgical valves, at least out to 5 years. And there is an increased risk of needing a pacemaker compared to surgical aortic valve replacement. So Pat Coleman talked to you guys a little bit about this last year, and at that time we'd only treated a handful of patients. Since then, we've treated 72 patients. Our average STS score in our program is about 6.43. That's higher than the intermediate risk trials because we have a lot of high-risk patients still, so we're above the 4.5 to 5.8 STS risk. But I've provided the data sort of on the right as sort of a benchmark of how we're doing. So 30-day death, 2.7%. We have had one peri-procedural death and one death at 29 days from a patient who transitioned to hospice related to other complications other than his TAVR. Importantly, we've had no disabling strokes, no vascular complications, and no patients with more than mild aortic regurgitation, all outcomes that we really strive to do really well on. And then our pacemaker rate's around 12.5%, which is in line with what the trials have shown. And our median length of stay is about 2 days. That's much less than what's shown in the trials, around 6 days, and we're working on lowering that even further. And I show you this because, as other people have told you today, really this is a team sport. It's really, I think that's a big change in medicine in general. And Tavor is one of these things that have really kind of brought to the forefront the importance of working in a collaborative team environment. We have interventional cardiologists, cardiothoracic surgeons. We have anesthesiologists, cardiac imaging specialists, both cath lab and OR staff, and a valve clinic coordinator. We have 4 implanting physicians, myself, Pat Coleman, Keith Corver, and Ramsey Deek from the surgical side. And we all work together, and it's been really remarkable working with these guys that have many, many years of experience implanting surgical aortic valves, and we've learned a lot, I think, from each other. We have imaging specialist, Dr. Sanjay Daur, who does all our echo imaging, and Dr. Ray Conway, who does all our pre-procedure CT scanning analysis. We have 3 great anesthesiologists, Darren Brandt, Shay Aiken, and Chris Press, who actually make the procedure incredibly stable for us and provide TE guidance. We have cath lab and OR staff who work tirelessly really to make our day efficient, and not everybody's on here. There's even more people than this involved, but allow us to get through a number of cases in a timely and efficient manner. And then last but not least, probably the most important person, Atusa, who's sitting here in the audience. She's our structural heart coordinator. She's incredibly important to sort of shepherd patients through the whole process, make sure patients have a good experience. She's the one that really makes sure we are all doing all the things we need to do to work these patients up and get them done in a timely manner. And she's here today, and I encourage you to talk to her and get her phone number in case you have any patients you want to send to the program. Okay, next I want to talk to you about MitraClip. So aortic valve disease is really common, and we've done a lot of TAVRs, but mitral valve disease is way, way more common. So after the age of 65, really, mitral valve disease is about 2 to 3 times as common as aortic valve disease. And really, it's going to be a huge problem with the aging population. One reason that it's a huge problem is that in addition to the numbers, so this is data from 2009, there's about 1.7 million people with severe mitral regurgitation. We only do surgery in about 2% of those patients, 30,000 mitral valve surgeries a year. So a significant proportion of patients don't ever have mitral valve surgery. And that's because they're too sick, too old, too many comorbidities. So there's a huge unmet need of patients that really need therapy. And it's really important because mitral valve disease is really bad. If you have severe mitral regurgitation, shown in yellow here, your survival is significantly reduced. 40% of those patients die at 5 years. Moreover, they have a significantly higher risk of cardiovascular events, such as cardiovascular death or hospitalization for heart failure. This is data from the Cleveland Clinic in patients with severe untreated mitral regurgitation. You can see that at 5 years, about half of them will be dead, and virtually all of them will have been hospitalized for heart failure. So an incredibly important problem. In general, we think of mitral regurgitation as two types, primary and secondary. Primary means there's something wrong with your mitral valve itself. This is the classic flail or prolapse patient that we see often. Secondary mitral regurgitation means there's nothing actually wrong with the leaflets themselves. There's something wrong with your left ventricle. Your left ventricle is dilated or dysfunctional, leads to tethering of your mitral valve leaflets or dilation of your annulus and malcoaptation. So the MitraClip procedure begins with a transeptal puncture. So a catheter is placed via the femoral vein across the interatrial septum. And there's this catheter that's advanced through that sheath, and there's a little clip here at the end. This catheter can be articulated in multiple planes, and it's usually placed directly over the mitral valve. You can sort of extend it and flex it depending on where you want to put it. And then the clip's opened, and then the clip can actually rotate in a number of directions to get it perfectly perpendicular to the opening of the mitral valve. Once you've got it in the place, you usually put it at the largest jet, mitral regurgitation jet. You can then advance it across from the atrium to the ventricle, and then you bring it up, and you remarkably can capture these leaflets that are moving. You can close it and reassess how much regurgitation there is. If there's a lot and you don't like it, you can let it go. You can make some adjustments, bring it back up, and reclip. And then you can see there's less mitral regurgitation. And what you've done is you've created this double orifice mitral valve. This is mimicking the surgical Alfieri technique of mitral valve repair. Once you're happy with it, you can then release the clip, and then that's it. You can also put in a second clip or a third clip if needed, just paying careful attention to not creating mitral stenosis by narrowing the orifice. So MitraClip was tested in the Everest II randomized trial. 279 patients. It was an all-comers trial, randomized, all-comers with primary mitral regurgitation, so flail or prolapse typically. And they were randomized 2-to-1 to MitraClip on the left versus surgery on the right. And we now have 5-year data in these patients. So let's start first, is the procedure safe? Because it sounds absolutely crazy. If you look, really major adverse events were really uncommon. So 15% with percutaneous repair as compared to surgery at 48%. Now, when you drill this down a little further, a lot of those events in surgery were transfusion of 2 units of blood. So if you take 45% of patients with surgery needed a transfusion of more than 2 units and 13% with MitraClip. If you take all those transfusion events out, you really get no statistical difference in major adverse events with percutaneous repair versus surgery, 5% versus 10%, though numerically lower with MitraClip. Still, I think that most people would say that MitraClip is safer than mitral valve surgery. But what about efficacy? So this is a graph of patients with moderate to severe mitral regurgitation, surgery in blue, MitraClip in red, and you can see that at baseline, over 90% of patients in the trial had significant mitral regurgitation. At 1 year, surgery is incredibly effective, reducing moderate or severe mitral regurgitation to about 1%, and that's a durable result with essentially no change at 5 years. With MitraClip, you still have about 20% of patients that have significant mitral regurgitation. But importantly, if you do achieve a good outcome, so these 80% here that don't have moderate or severe mitral regurgitation, it doesn't seem to grow at 5 years. So there's really no change. So if you get a good result on initial implant, that seems to be durable. So MitraClip is not as effective as surgery at reducing mitral regurgitation. But it turns out patients don't really care whether they have moderate or severe mitral regurgitation. They care whether they feel better and live longer. So when you look at New York Heart Association class, patients with functional class 1 or 2, so doing pretty well, at baseline about half of the patients in both surgery in blue and MitraClip in red have class 1 and 2 symptoms. Interestingly, at 1 year, similar numbers of patients who get MitraClip versus surgery are functional class 1 or 2. Granted, some people with MitraClip will have crossed over to surgery, but still, the strategy of treating with MitraClip up front doesn't seem to affect your functional class at 1 year. And same thing is seen at 5 years. Looking at mortality at 5 years, so MitraClip in blue, surgery in red, 81% of patients with who get a MitraClip will be alive at 5 years versus 79% with surgery. No difference in survival. So surgery and MitraClip result in similar improvements in NYHA class and survival. Quality of life also is similarly improved. There's improvements in, this is data from high-risk cohort of the Everest trial and a high-risk registry. So, your highest risk patients, and you can see that quality of life, both in the physical component and mental component, improve after mitral valve surgery. If you look at high-risk patients who get mitral valve surgery, so in this study, in this cohort of patients, the expected STS in these patients was around 12%. After MitraClip, the 30-day mortality was only 4.8%, so significantly lower than what would be expected from surgery, sort of adding to the safety of the data of the safety of the procedure. So the FDA initially approved MitraClip for patients with a degenerative or primary mitral regurgitation at prohibitive risk for mitral valve surgery, and that's as judged by the heart team. Recently, we've had really exciting data from the publication of the COAPT trial. So the initial MitraClip studies were in patients with primary mitral valve regurgitation. This study tested patients with secondary mitral regurgitation, so patients with bad ventricles with a lot of mitral regurgitation, and randomized them to guideline-directed medical therapy versus guideline-directed medical therapy plus a clip. And importantly, this is a population where surgery has never really been proven effective. We've had no therapy to treat these patients except for really putting them on ACE, beta blocker, spironolactone, and biventricular pacing. And it was overwhelmingly positive in favor of MitraClip. In green is patients with MitraClip, and blue is just patients who got medical therapy. 50% risk reduction in cumulative heart failure hospitalizations over 2 years. And not only was it positive for heart failure hospitalizations, it was positive for death. There was a 40% risk reduction in terms of death, a number needed to treat of about 6 patients to save 1 life over 2 years. So very effective. And based on this, actually in March, the FDA approved the MitraClip to help difficult to treat heart failure patients with clinically significant secondary mitral regurgitation. And this really expands the therapy to a much wider range of patients. What's the future? This is the mitral space, actually probably the most exciting space in terms of structural heart interventions, because there's a number of startup companies out there looking at different therapies they can offer. And some of these are approved in Europe, some are being tested here in America. Mitral annuloplasty, so a therapy to reduce the AP diameter of the mitral valve. This is the cardioband device here, where percutaneously across the transeptal puncture, you can advance these sort of pledget type things and then cinch the mitral valve. This is a direct percutaneous annuloplasty. People are looking at indirect percutaneous annuloplasty, leveraging the coronary sinus to sort of narrow the mitral annulus. And this is the millipede device. This crazy looking device can actually be inserted percutaneously without opening somebody's chest, which, I mean, it looks absolutely insane, but it can be done. And these are all being tested right now and probably will expand our ability to treat patients with significant mitral regurgitation. Mitral valve replacement is also rapidly changing. These are 4 devices that are all being tested for mitral valve replacement. This is the Edwards Sapien Tavor valve, but it's being tested with a different nitinol docking system to be able to percutaneously replace the mitral valve. This is the Edwards Cardia AQ, the Medtronic Intrepid valve, and the Abbott Tendyne valve. So a lot of research going into this space, and probably the way we do mitral valve replacement, I think, will change in the next 5 to 10 years. Okay, moving on. Left atrial appendage occlusion. So we all know that atrial fibrillation is incredibly common. We see it every day in our practice, I think. It's really just probably the #1 diagnosis, I think, in most cardiology practices these days. And we all know about the CHA2DS2-VASc score. And as the CHA2DS2-VASc score goes up, stroke risk goes up with atrial fibrillation. But it turns out that actually CHA2DS2-VASc is a really good predictor of bleeding risk. And as your CHA2DS2-VASc score goes up, your bleeding risk also tends to go up. Reflecting this, you can see that in the, this is data from the NCDR Pinnacle registry of over 400,000 patients. And if you look at patients who have a high CHA2DS2-VASc score greater than 2, who would warrant anticoagulation, half of them don't get appropriate anticoagulation. Similar, if you look at CHADS VAS score, over half of them don't get anticoagulation. And this is probably reflective of our perception or the patient's actual risk of bleeding. So a large proportion of patients are left unprotected from stroke with atrial fibrillation and high CHADS VAS score. It turns out that in atrial fibrillation, particularly non-valvular atrial fibrillation, 91% of the thrombi originate from the left atrial appendage. So it sort of stands to reason that if you can occlude the left atrial appendage, maybe you can eliminate patients' risk for thromboembolism without a systemic therapy such as warfarin or a direct oral anticoagulant. So this is where the watchman procedure comes in. It's a one-time implant. It's implanted via the femoral artery through a transeptal puncture into the left atrial appendage. It's this nitinol structure covered with a membrane, and it's performed by a member of the heart team, an electrophysiologist or interventional cardiologist or cardiac surgeon. And it's done usually in the cath lab. You don't have to have a hybrid OR, general anesthesia, 1 hour procedure, 1 to 2 day stay. After the device is implanted, over time, it becomes endothelialized. This is a pathologic specimen of a patient who died from complications unrelated to the watchman. And you can see this watchman device here. It's now endothelialized, effectively excluding the left atrial appendage from the systemic circulation. So initially when the watchman data came out, I think a lot of people were concerned about the safety of the procedure. And when the PROTECT AF trial was initially started, in the first half, there was a very high event rate of adverse events, around 10%. But as operators got more and more experience at implanting these devices, they've gotten better and better. And 4.8% in the second, there was a 4.8% risk of adverse events in the second half, and it's continued to steadily decline. And in the most recent evolution registry, it's around 2.8%. And even with new operators, the risk is quite low at 4.1% in the PREVAIL study. So the procedure is clearly becoming safer. All sort of metrics of adverse outcomes are also going down. Tamponade, which was a big concern in the initial initial trial, 4 to 4.5%, is now down to 1% or less. Effusions are down. Periprocedural strokes, which was a big concern, is down to 0.1%, and device embolization 0.2 to 0.3%. So much safer procedure. What about efficacy? So the watchman is actually just as efficacious as warfarin. If you take all the data that's been published and meta-analyze it, you can see that for stroke or systemic embolism, no difference between watchman and warfarin. Ischemic stroke tends to seem to favor warfarin, though statistically no different. Particularly hemorrhagic stroke is clearly reduced with watchman therapy compared to warfarin, and that makes sense because these patients will bleed less. And because of that, disabling or fatal stroke is probably less with watchman. There's been this signal of decreased mortality in a lot of these studies, and we're not sure why that is, but some people posit that maybe it's related to bleeding because patients are no longer taking systemic anticoagulation. If you take registry data and plot in the dotted blue line, stroke risk based on patients' CHADS VAS score. The dotted blue line is patients without warfarin. The solid red line is patients who are on warfarin. And you plot then against that all the watchman data of stroke risk based on the CHADS VAS in each trial. You can see that you achieve essentially a warfarin-like effect with each study. So this kind of adds to the idea of the efficacy of the procedure for reducing ischemic stroke. So watchman was initially indicated for, is indicated for patients with non-valvular atrial fibrillation who have an elevated CHADS or CHADS VAS score, who are suitable for warfarin and have an appropriate rationale to seek a non-pharmacologic alternative to warfarin. So all your patients out there who have atrial fibrillation with an elevated CHADS or CHADS VAS score, who are not on some type of anticoagulation, really would be good candidates for a watchman procedure. Santa Rosa Memorial will go live with this procedure, I think, on May 17th, and Dr. Bedi from electrophysiology and Dr. Cheng Singh are both going to be implanting them. Okay, and then last, I want to talk to you about PFO closure. So PFO closure is pretty common. It occurs in about a quarter to a third of the population, and the majority really are asymptomatic. But when looking at patients with cryptogenic stroke, it turns out there's a much higher prevalence of PFO in patients with cryptogenic stroke. So people have wondered whether these could be pathologic and cause paradoxical embolism, basically from the right atrium to the left atrium to your brain. As of 2016, we really had no data on whether we should close these things or not. It made sense that we should close them, but a neurology practice advisory basically said clinicians should not routinely offer PFO closure to patients with cryptogenic stroke outside of a research setting. And that was largely based on a couple of trials published in the New England Journal in 2013. So this was the RESPECT trial as well as the PC trial, and they basically took patients with cryptogenic stroke with a patent foramen ovale and randomized them to closure or medical therapy and followed them for strokes. And you can see that the hazard ratio in both trials crossed 1, suggesting that the therapy wasn't effective. Fast forward about 4 years later, and we had 3 trials published simultaneously in the New England Journal in September of 2017. The RESPECT late trial, which was a late follow-up of the RESPECT trial I just showed you, the Gore reduced trial, and the closed trial. They're all kind of similar trials. They took adults less than 60 with cryptogenic stroke, no other cause of stroke as determined by neurologist that had other than a PFO, and then they had some type of shunt shown, like either a large shunt with some, but all had to have a PFO with a right to left shunt. And they were randomized to closure or some type of medical therapy, antiplatelet, anticoagulant, and they were followed for a variety of outcomes. Actual clinical stroke or MRI evidence of stroke or stroke and death. And all 3 trials were positive. And this journal is actually a total game changer for PFO closure. If you meta-analyze all of this data, there's about a 50 to 60% reduction in recurrent stroke events for patients with PFO and cryptogenic stroke. So something that we should all be considering. What about is the safety of the procedure? Well, it turns out the procedure is actually incredibly safe. Very few complications occur with PFO closure other than atrial fibrillation. There seems to be about a 4-fold increased risk of atrial fibrillation with PFO closure. That's usually transient and self-limited. So while a complication is not something that I think is clinically that relevant. So really, who should you consider for PFO closure? So your 60-year-old patients or 60-year-old patients or younger with cryptogenic stroke and a PFO, and especially those with a large shunt or an atrial septal aneurysm. And I put an asterisk there because older patients who've got a recurrent stroke, large shunt or atrial septal aneurysm or DVT could also be considered for closure, I think. All right, a lot of data, but with that, I'll take any questions. Yes? You don't have to anticoagulate for MitraClip. Yes? I think there. Yeah, so mitral stenosis the procedure's done with TE guidance, and at the time of the implant, before you even release the clip, we actually test the gradient across the valve, and if there's significant mitral stenosis, then the clip won't be implanted. In terms of embolization, with operator experience, device embolization is really rare. There was some issues initially with single leaflet device attachment initially, but that's really a rare event now with increased operator experience. Yes?
The watchman procedure you compared that embolism what about the DOACs?
Yeah, I think we'll let Dr. Bedi answer that one.
Why don't we invite our panel
Yeah.
discussants and then we can field more questions from our team.
So for Watchman, the question was, were there any comparisons made between Watchman and the novel anticoagulation medications? So most of the data is coming from warfarin, but it's comparable to some of the novel anticoagulants. I understand that the bleeding risk is slightly less in some of the novel anticoagulation medications comparison to warfarin, but in these, most of the data is compared with Coumadin and warfarin, and some of the registry patients in evolution, they were on novel anticoagulation medications. Even that data was very suggestive that there is a significant decrease in the risk of bleeding And I mean, these patients are actually not candidates for novel anticoagulation medications because of increased bleeding risk or whatever reason we are not choosing the anticoagulation medications. But the initial inferiority trial, the PROTECT AF was between they compared Coumadin and Watchman.
Any other questions?
Gene?
With the prevalence of the PFO you described, how do I know whether I'm going to be at risk for having that? I'd rather know about it before I have my stroke.
Yeah.
You need a TE.
So about 25% of the population, they have a PFO. So if they have a PFO, that's not an indication for a PFO closure, but if they have a cryptogenic stroke and they are less than 60 years of age, they are usually the candidates. And as Vishal mentioned, that some of the older patients who have cryptogenic stroke and increased risk, I mean, they can also get PFO closure device.
Yeah, I think your question was, how do I know if I've got a PFO? You need an echo with a bubble study.
Exactly.
I'd take an aspirin.
Yeah. I don't think there's any good data on what to do as a primary prevention. Yeah.
Because Gene wanted to know.
Yeah.
Yes, sir.
Concerning the Tavor, with the lower risk study that currently came out, was there an analysis looking at conversion to open surgery with that population?
So during the procedure, how many got converted to open?
Well, I understand with the high-risk patients, probably less were converted to surgery because of their high risk that led to them being put in that stratification. But with the lower risk patients, what's their conversion rate to open
It's
surgery?
incredibly rare.
It's less than 0.2%.
Yeah.
And if you look across the board at all comers these days, what is the conversion to an emergent open surgical procedure? It's about 0.6 to 0.7%. So it's really low.
Something a little different on the topic. I've been reading that for congestive heart failure, they're suggesting surgery in the atrium for that. Are you aware of that, or is that something I'm just making up?
There's some interesting, and Ash may have some other ideas, but there's some interesting ideas about creating baffles for people with pulmonary hypertension and shunting for patients with pulmonary hypertension. But that's really wild and crazy.
Yeah. It's like the idea of you alleviating pressure in the left atrium as a shunt to the right atrium. And I think that's in research trials right now.
Yeah.
And if we do have a patient who's appropriate, and we think may be appropriate for one of these procedures, should we refer directly to interventional cardiology? Should we go through our cardiology generalist?
Well, mainly, if first of all, thank you guys for all being such great primary care docs and being on the front lines. You're going to pick up people who have lots of symptoms, and you're going to hear a murmur. And at that point, you need an echo and a referral to a general cardiologist. And it should be a conversation between you and the patient and the general cardiologist. Is this something that's fixable, and then can you get to the guys who are doing it?
Most of these devices, they need a shared decision, so it's between a general cardiologist and the interventional cardiologist, or neurologist and electrophysiologist. So it's always good to have a shared decision making in most of these devices.
One of the things I wanted to point out that's always a question when Vishal was talking about non-valvular atrial fibrillation. Valvular atrial fibrillation refers to people with moderate or severe mitral stenosis.
They changed the guideline, yeah.
So it's not somebody who's got MR. Okay, so when you're thinking about those people, it's just that rare group that has moderate or severe mitral stenosis that would be considered valvular.
And they have a prosthetic prosthetic heart valve. You know, those are the patients who are valvular atrial fibrillation, and patients who don't have a prosthetic valve, and even mild mitral stenosis is not considered a valvular atrial fibrillation. All right.
All right. Thank you very much.
Keith.
Oh,
happening in front of my eyes. And I would like to ask, sort of in jest, but sort of like realistically, where do you see the role of cardiac surgery 5 years from now? Because it's, you know, from my perspective, it's obviously something important, but also, you know, you wonder about how much, you know, where cardiac surgery will be. Will it be in every hospital? Will it be, like, how many cardiac surgeons you're going to need? And I'm just sort of wondering if you could each comment on it. I mean, in cardiac surgery circles, there's obviously a lot of angst about it, but I'm just sort of, I mean, I know this puts you on the spot a little bit, but I'm just kind of wondering what you think, like 5 years from now, how much cardiac surgery you think there'll be, how much less. I mean, it's clearly going to be in a diminished, probably capacity, but I was just wondering on your comments on that.
Well, first of all, your work will never be diminished in our eyes. But I think it's a good question. It's something that you and I have talked about before. I think that at least as far as aortic valve intervention goes, there'll be less aortic valve surgery. But one of the things that we've found with Tavor, now that we're looking at valves more closely, is there's a lot more bicuspid aortic valve disease out there than we previously appreciated. And those people develop an aortopathy. And I think one of the things that's going to be really important to look at Tavor going forward in the next 5 years is, gee, we've done Tavors on the aortic valve, but now 5 years later, they have a big aortic root aneurysm, and now we've got to send them back to surgery. So I think we're going to be defining roles where surgery actually is more important or better at fixing their overall problem rather than just their aortic valve problem. I think that as far as mitral intervention, we've still got a long way to go because it's weirdly shaped, it moves, it's dynamic, there's no place to grab onto the mitral valve. It's a high pressure closure as opposed to a high pressure opening. So it's a whole different animal than aortic valve. And I think the things that Vishal talked about and other than MitraClip, they're ways off.
At the same time, I also feel that some of these patients who have significant valvular disease and concomitant atrial fibrillation, mitral valve surgery or repair with concomitant maze procedure and left atrial appendage occlusion or excision, I think has a big role to play in a lot of these patients who are very sick and they have bad congestive heart failure too. I think there is a big role, and in the EP word, I mean, whether it comes down to maze procedures, lead extractions, and some of the epicardial ablations in a lot of patients, I think surgery has a big role to play besides, I can talk about the EP perspective.
Thank you.
Cut it off there, and we have a big agenda.
Thank you, guys.
We'll be happy to answer questions at the breaks.
So let's. Thank you to our structural heart team and Dr. Vishal Patel. The fact that we're going over a little bit is a good sign because everybody's very engaged in what we're doing, and engagement is important as we learned this morning. So let's go ahead, we'll take a break.